Hello, this is Jeff Swenson from the University of Utah Orthopedic Center. Wanted to talk about peripheral nerve catheters and share some of the information we've accumulated over the last 10 years. First of all, we'd like to ask the question, why catheters? And the answer to that is, to date, there's still not any other way to get the flexibility of block duration and density that we want without a catheter. In other words, we can place a catheter and make the patient as dense or as lightly anesthetized as we would like. We also have the flexibility of making the duration of the block tailored to the patient's needs. It's been known for a long time that continuous nerve blocks are superior to other forms of conventional analgesia, such as opioids, that they reduce opioid requirements, opioid-related side effects, sedation, and also significantly reduce VAS pain scores. When compared to single injections, continuous nerve blocks are also favorable in that they reduce pain scores, opioid requirements, nausea, and increase patient satisfaction. At the University of Utah, we've placed more than 8,000 ultrasound-guided catheters. Each one of these patients has gone home with the attending anesthesiologist's cell phone number, so we've been able to not only do some controlled studies but also observe patients' likes and dislikes over the years. Some practical questions we'd like to explore today are, what about Exparel, the long-acting bupivacaine liposomal local anesthetic? How long should catheters take to place? Do I need a nerve stimulator? Do I have to use a Tuohy needle? Some practical tips that we have accumulated over the years, cost containment, and what happens with my outpatients. How long should a catheter take to place? We've used this unedited video of a femoral catheter being placed, and you can see there the needle indenting the surface of the fascia lateral to the nerve. And now we're hydrodissecting and injecting local anesthetic in a plane deep to the fascia iliaca, passing over the femoral nerve and deep to the femoral artery. This is a pretty classic appearance of this dissection. The answer to the question is not very long. You will see that there's a slight indentation of the needle there, and it's going to withdraw again. And then in that same location, which is about 1 centimeter or 1.5 centimeters away from the nerve, we will see the catheter indent the surface of the iliopsoas muscle lateral to the femoral nerve. So here comes the catheter right here, passing on the surface of the iliopsoas muscle. So to answer the question, about 45 seconds is how long this took, and that's really how long most of these catheters should take to place after you've gotten all of your equipment together. Exparel is a liposomal bupivacaine that was approved by the FDA for single injection wound infiltration. It is currently not approved for peripheral nerve block, although there are some studies publishing early data on this for peripheral nerves. It ideally produces analgesia for up to 72 hours, as claimed by the manufacturer. It's available as a 1.3% solution, that's 13 milligrams per ml of bupivacaine. The wholesale cost of one vial is $285. Now the retail or patient cost will be significantly higher than that and will vary depending on different hospitals. One of the first studies looking at wound infiltration and analgesia was performed in hemorrhoidectomy patients and published in 2011. In it, the authors reported a reduction of 30% in cumulative pain scores and a 45% reduction in opioid consumption over the 72 hours following surgery. In this table, however, we can see that this is a cumulative table, meaning the intervals measured are not the exact amount used in that time period. In actuality, the first 12-hour period that was measured had an 8.5, this is morphine equivalent, difference between the depot foam or Exparel bupivacaine category and placebo. If we look at the subsequent 12-hour intervals, however, we can see that there is very little, if any, difference between the opioid requirements for rescue medication between the placebo group and the depot foam group. In fact, in 4 of the 5 time intervals, the depot bupivacaine group actually required slightly more rescue medication. So we're still looking for more information on this drug, on how useful it will be, and especially from an anesthesiologist standpoint, how useful it will be for single injection peripheral nerve blocks. Another study performed in 2012, the knee, looked at pain scores over 5 days. In this case, there was only a significant difference in pain scores between the liposomal bupivacaine and traditional bupivacaine in the first day. In subsequent days, there was not a significant difference until day 5. It's curious that this would occur in this pattern, and there are still lots of unanswered questions about Exparel. To TUI or not TUI? And our suggestion is, if it helps you with tactile feedback, great. Otherwise, we do not use any blunt needles at the University of Utah. And as I mentioned before, that's with over 8,000 catheters placed successfully. How did we start using B-bevel needles in the first place? One of the first studies suggesting that B-bevel needles were safer to use for regional anesthesia was published by Dag Selander in 1977. It was a rabbit study on the sciatic nerve, comparing 14-degree versus 45-degree angled bevel needles, and the actual nerves were examined under fluorescence microscopy, so there was no functional outcome. And the authors concluded that there was more damage with a sharp needle than a blunt needle. Subsequent to that, there was a study published in the British Journal of Anesthesia in 1992 in rats, where they looked again at long versus short bevel needles, and they also looked at functional assessment of the nerve in this animal population. Interestingly, in this study, the short beveled or B-bevel needles caused more injury that took longer to repair than the long bevel or sharp needles. So what kind of needle do we use? I think people who enjoy having a real sense of passing through fascial planes are more prone to use a blunt needle. Whether or not this is safer is yet to be proven in the literature. Most of those are more expensive. Sharp needles don't hurt as much, obviously. Whether they cause more nerve injury, again, is a matter for discussion, and they seem to be less expensive. In our institution, we use a simple 18-gauge thin-walled needle to place all of our catheters. What about nerve stimulation? I think nerve stimulation for regional anesthesia is an academic debate of the past. Ultrasound guidance compared with electrical stimulation in meta-analyses has consistently shown superiority of ultrasound. The authors of this major meta-analysis published in the British Journal of Anesthesia stated, none of the trials published to date has demonstrated superiority of peripheral nerve stimulator compared to ultrasound guidance. So that will end our discussion of nerve stimulators. Things that have made life easier for us. We have a catheter kit that is much like a Swan-Ganz catheter introducer port, where we place the peripheral nerve catheter through a diaphragm and pass it into the needle, so this is already engaged. That makes it so that as soon as you're done injecting, you don't have to disconnect the needle. You simply grab the catheter and thread it into position. It's very, very nice, especially for upper extremity, where small movements when you disconnect the needle from the tubing can be a bit cumbersome. The other thing is a very flexible tipped 20-gauge catheter that we use has made passing a catheter into the interscalene space much, much easier. We also use a catheter stabilization device for some catheters in the upper extremity and occasionally in the lower extremity, but they've helped us tremendously for interscalene blocks. Catheters. This is a double stick tape that goes on first superior to the catheter. The Velcro is then torn back. The second adhesive layer is exposed. The catheter is laid over that double adhesive section, and the Velcro is replaced, making a nice snug catheter stabilization device. We then put a sterile tegaderm over the whole dressing to that point and cover that with a 4x4 and a micropore tape. There are many ways to dress catheters. This just happens to be the way that we use it and works for us. This is a very important piece of adaptation for sending people home with catheters. We simply make a loop in the catheter and tape it so that when there is tension on the catheter itself, it does not apply directly to where the catheter is inserted into the connector. We've prevented a lot of disconnects by doing this little loop with the tape. Also, when you get a call from a patient at home saying that they have had a catheter pull out, sometimes over the phone it's very difficult to explain how to open up that connector so that you can reinsert the catheter. And in this case, a picture is worth 1,000 words. So rather than trying to describe the yellow part and the clear part, I simply have a picture of this on my cell phone that I send to them, and they are very, very happy and it's very easy for them to open the connector and reinsert the catheter if this happens. You can perform real-time injection of agitated contrast. This is an example of that occurring in a femoral nerve catheter to confirm where your catheter is. I would caution you that for lower extremity catheters, it can be very difficult to see your agitated contrast while you're injecting it because the catheter most likely has gone cephalad or caudad from the beam of the transducer. So if you don't see it, don't be discouraged and try looking superiorly or inferiorly if you can't see it at the image that you're using, because this can be tough. This is one other example of the same thing with the brachial plexus catheter. Unlike lower extremity, it's usually very easy to see agitated contrast injected into a catheter in the brachial plexus above the clavicle. And lastly, this is a sciatic nerve catheter where we're injecting, showing agitated contrast adjacent to the nerve. So using agitated contrast to confirm your catheter placement is a very specific sign. It's not as sensitive because, especially in lower extremity, the catheter may have passed cephalad or caudad to the beam of the transducer. How about keeping costs down? If we look at the cost of needles, if we use just a 18 gauge introducer needle and a 20 gauge polyamide catheter, that cost together for those two is about $8. So for 1,000 blocks, we'd spending about $8,000. By contrast, if we use a nerve stimulating needle only but a plain catheter, that cost is going to be about $21 or $22. The annual cost for 1,000 blocks would be close to $22,000. And lastly, if we use a nerve stimulating needle as well as a nerve stimulating catheter, that cost will be about $57 and $57,000 a year for 1,000 catheters. So you can see if you are having to pay for this out of pocket, there are a lot of things you could probably do in your department for almost $50,000. Ultrasound machines happily have been getting cheaper and cheaper as time goes on. If we look at the approximate cost in US dollars for the early console machines in 2000, it was about $120,000. That reduced to $45,000 in the mid 2005-2006 area. In 2009, we had the introduction of compact machines for about $25,000. And now handheld devices will be out on the market after 2010 and beyond for approximately $8,000. The weight of these devices has dropped dramatically too, from the earliest units being 320 kilograms down to 3.5 and finally half a kilogram. This equipment comes in one kit for us, and we can put a catheter in with a full bottle of bupivacaine for 2 days. Our cost is $67, so that's pretty inexpensive. This is a bare bones kit that is made custom for us. What about pumps? There are a number of different types of pumps, and realistically, pumps are probably the area of biggest disparity in cost when we place catheters. There's elastomeric pumps that are basal only that sell for $40. Baxter, unfortunately, is discontinuing this model, and we have had to look for a new supplier that is slightly more expensive than this. If we go on to the on-cue block elastomeric basal bolus pumps, those are $250 to $500, and lastly, the AmbiIT electronic reusable pumps can be anywhere from $500 to $800. Is there any benefit to having a basal bolus or basal only pump? And there have been a number of studies looking at this. In one particular study by Ilfeld in the sciatic nerve at the popliteal fossa, they had 3 groups, one with basal only, one with basal bolus, and one with bolus only. And the authors concluded that adding patient-controlled bolus doses allows for a lower basal rate and decreased local anesthetic consumption. When they performed the same study in infraclavicular catheters, their conclusions were that continuous infusion with patient-controlled bolus optimizes analgesia and minimizes oral analgesic use. I think it's worth noting, though, however, that the average pain score was 2, and there was no difference between the groups in the average pain scores between basal and basal bolus groups. The mean opioid use was only 6 oxycodones in 48 hours. So when we're looking at these, we have to say decide if something that is statistically significant is clinically significant, because I would submit to you that if someone is only taking 1 5 milligram oxycodone about every 8 hours over 48 hours, that's a person who is fairly comfortable. There have been other studies also looking at patient-controlled perineural analgesia. In this particular study, randomized clinical trial, the authors stated that patient-controlled anesthesia bolus doses optimize functional recovery and pain relief while decreasing the consumption of rescue analgesics. When we look at their raw scores, however, for visual analog scores, we can see that the black column is PCA, the white is continuous infusion, and the shaded is the basal bolus group. And if we look at the 3 columns here, we can see that although there's a difference between the morphine group and both catheter groups, the pain scores in the continuous catheters are actually lower on day 2 and not significantly different on day 1. So there's not a huge amount of data showing that basal bolus is any better than basal only if the catheter is correctly positioned. Likewise, when the authors looked at patient satisfaction, what they found was that the absolute numbers of patients who were either very satisfied or satisfied was exactly the same, 80% for the basal as well as the basal bolus groups. So you have to decide whether it's worth it to you to pay over $250 or $300 for a pump that has a bolus capability when basal infusions seem to have performed just as well. Patient follow-up is very important, and patient education saves call to you, the provider. Some of the most important information you can convey to your patients is side effects, and Interscaling probably poses the most side effects of most of the blocks that we do. It's very important to remind them about ptosis, conjunctival injection, diaphragm weakness, and recurrent laryngeal nerve effects. We give our patients teaching and written instructions. Also, it's important to tell patients that some leakage under the dressing is normal, that they need to protect their extremity if they can't feel it, and that they are able or can take pain medicines if they need them. Some people think that a catheter and pain medications are mutually exclusive, so you need to make it clear to them they can take pain meds. And one of the most common questions we get is, I don't think this bottle is emptying because it empties so slowly. So point out to them that the bottle will not appear to be emptying because it goes so slow. And lastly, how to and when to pull the catheter. And gravity does not alter flow. A lot of people are concerned about where they have to put the elastomeric pump if it's gravity driven, and we all know that that's not an issue. So I always tell the patients to put it wherever it is comfortable for them. It's very important to have outpatient follow-up. If you look at the bottle on this patient's shoulder, you'll see that we have the cell phone number of the anesthesiologist. There's nothing more discouraging to a patient who's recovering from surgery and has a lot of things to worry about than to get passed from one person to another. So we like our patients to be able to get us immediately on the first call so we can deal with any questions that they have. As you know, we've published a very early study back in 2006 of 620 outpatient catheters. The intervention rate, meaning where the number of times that the anesthesiologist actually had to do something for the patient, was only 4%. Now, since this time, obviously we have now put in over 8,000, and we continue to have very good results. All of our patients are called on postoperative day 1. It's very important to get a reliable phone number because the number on the chart may not be the one that they want everybody calling. So you really need to say, if I have to get in touch with you, what number should I call? We always remind them when we call them at home to tell us if they're getting adequate pain control, and remind them when and how to pull the catheter. We didn't have any infections in our group. We had one patient who could not remove the catheter. It had a small knot in the length of the catheter, which simply required a little tugging to get through the dermis. We had one patient readmitted for pain control. The interesting intervention rate on nights and weekends was only 1%. Complications include infection, local anesthetic toxicity, limb neglect, and nerve injury and falls. Infection risk is a real concern because we are doing something that is not absolutely necessary for the surgery, and so if we have a complication, it is a bit more of a tragedy than if it were the surgery itself. That's why we are very careful about infection. We use a fenestrated drape that has adhesive borders, so this center area here is prepped with ChloraPrep, but as you will see, the adhesive border is between the needle and the transducer, so the transducer is actually outside the sterile field and the needle is inside the sterile field. Infection risk, the one thing that I think is important to drive home is that if you look at all of the larger studies of outpatient catheters and inpatient catheters, the one thing that comes through is that duration of use greater than 48 hours is the unifying factor with most of these studies. Most of the studies found that leaving the catheter in over 2 to 3 days was associated with a greater risk of infection, even though that risk was fairly small. We did not have any infections in our study, but we only leave our catheters in 48 hours. Occasionally, if a patient is a real special case, we will take down the dressing, look at the site, and if it looks good, maybe hook up another bottle and let them keep that for another day or two. But our routine is to limit it to 48 hours. Less is definitely more. When we look at multimodal analgesia, remember that we have many options we can use, and small doses of each of these working together helps us get total pain relief. We don't have to do it all with the block. When we say that, the reason we say that is over the years, after talking to thousands of patients, patients don't like having a dead extremity. And it's easier to avoid limb neglect and patient falls if they are not completely motor and sensory out. Also, when you're using low doses of local anesthetic, it's hard to cause any toxicity or harm when you're only giving 0.125% bupivacaine at 5 mL per hour. So that dose is very safe in outpatients. Also, when we looked at diaphragm function after interscaling plexus block, we had a double-blind randomized study comparing 0.25% bupivacaine and 1/8% bupivacaine. And what we were specifically looking at here, and as I mentioned, this is a randomized double-blind study that was restricted to only arthroscopic rotator cuff repair. So it was a very tight group of patients, and we wanted a very similar procedure so that we didn't have procedures of greater and lesser pain to test this hypothesis on. So doing this, we found that both groups had pain scores of 0 to 1, but there was significantly improved motor function, specifically of the diaphragm, in the patients who got 1/8% versus 0.25%. Only 21% of the patients with 1/8% bupivacaine showed diaphragm impaired movement versus 78% in the 0.25% group, and this was measured by ultrasound. Also, we had a higher oxygen saturation in the lower concentration group, and many of you know that with interscaling blocks, one of the things that can keep a patient in the hospital is low saturations. So we definitely had better saturation, better diaphragm function in the 1/8% group. We did not compromise pain control by doing that. In lower extremity, one of the big concerns for orthopedic surgeons after joint replacement is being able to have the patient ambulate safely on postoperative day 1 or the day of surgery. There has been a lot of talk regarding physical therapy and knee replacement and the inability to perform walking or therapy with a femoral nerve catheter in place. And actually, we looked at this in 77 patients who were getting continuous nerve blocks with 1/8% at 5 cc's an hour, and lo and behold, 45% of our patients walked on the day of surgery, and 100% walked on postoperative day 1 with 62% climbing stairs. There were 0 patient falls. This trend that we saw also in our study suggested that in those patients who were not able to walk on the day of surgery, a number of them had spinals, and the spinal was not completely worn off, and so it was not necessarily the block that kept them from walking, but the fact that they still had enough sensory and motor loss from their spinal late into the evening that they were not able to attempt ambulation that day. Our current practice is to use 0.1% bupivacaine 20 mL for our initial dose on an interscaling catheter and follow that up with 0.1% at 5 mL per hour. For lower extremity catheters, we usually use 0.125% bupivacaine 30 mL. Occasionally we will use 0.25% for some foot and ankle cases or osteotomies, but these are all followed by a continuous infusion of 5 mL per hour at 6 so that's a total of 6.25 milligrams per hour for the continuous infusion. These total doses of 20 milligrams and 30 milligrams, 38 milligrams to institute the block are very, very safe. It's nice to know that if we even accidentally injected the whole syringe on an interscaling, it would be the equivalent of 4 cc's of 0.5%, so it's a very, very safe dose. So blocks and catheters are great if they are safe, if they're fast, if they're reliable, if they're cost effective, and if we have patient education and physician access by the patient and careful follow-up, and if they are of limited duration.